Good morning, everybody from Mount Sinai, New York. And thank you for this opportunity for us to show this complex case. And we know Dr. Sharma is right there. We call him ubiquitous. 1 minute he's here in New York, next minute he's in India somewhere. So today is moderating rather than doing the case with us. We can start showing the slides. Okay, before that, let me just introduce myself, Dr. Annapurna Kini. I'm the director of the Cath lab here. I have Amit Huda, who is the associate for our fellowship program. He's going to be working with me today. I am Neil Patel and Pratish, who is our fellow, and Purvi. Sorry, Prithvi, not Pratish, Prithvi. And then we have Will, Elena, and technicians are Asif and Naira. So we can start showing the slides.
Yeah, and here also, as you see in the agenda, myself and Ramesh,
You guys have to come
other
here.
people, a lot of names written, but probably 2 or 3 of them are there. We have Dr. Data, and actually, tough to say who else is here.
Yeah, and other person from our imaging is
Yeah.
Kis, right here,
Yeah,
Kiski.
we have a good chairperson, faculty members, Dr. Rajavu Pawar, Dr. Sanjeev Sarma, Dr. Sanjeev Sangvi, myself, Dr. Nahata, Dr. Sanjay Tug, Dr. Sunil Beniwal. There is a good house of for scientific session. Thank you, madam. Yes, carry on.
Great. And we don't have anything to disclose. So this is the case for today. She's a 71-year-old female who actually presented with a progressive angina. So from class 3 to almost class 4, couple of episodes of rest angina, and you will know why she's having rest angina with the SAQ score of actually 46. The lower the score, then you know significant the angina is. So risk factors, mostly controlled hypertension, diabetes, hyperlipidemia. She has been on therapy for all this, but one of the I think I know we have written all her risk factor numbers. LDL is 60. Look at the hemoglobin A1C 7.8, slightly higher than what we would want. One measure was not there and we just got it. Her CRP actually is 5.3. So it's not, so she just did a exercise treadmill with chest pain during the treadmill. So she was actually urgently added on yesterday for angiogram. So she was on all the medication you see there for her diabetes, hypertension, which controlled her, good therapy for angina also, but we added Clopidogrel yesterday. So we did a cardiac cath yesterday. We showed significant 2-vessel disease, proximal RCA disease, and I'm going to show you distal left main, which was calcified, proximal LAD calcified, involving a moderate, small to moderate size diagonal. More important, EF was 60, syntax score of 26. So we did the RCA PCI. The question was somebody diabetic, left main, involvement of the LAD, why surgical opinion was not taken, or could it have been done based on the current guidelines, and where we are, 2-vessel disease, proximal LAD is still appropriate even since the syntax score is intermediate. Discussion with the patient, but more important, referring cardiologist, we felt that let's just proceed, because right now the most important thing that we do is heart team discussion. So patient as well as the referring cardiologist heavily involved, and then we make a decision: do we do PCI or can we go for we have to refer something else. So that's why we did the RCA, and this is where it was. Look at her rest pain is probably both from RCA. You can see despite nitro, she had significant proximal disease, and just at the level of the RV branch, 80-90%, we had to do 2 stent. One single 48 millimeter could not cover. So that's where we are with her. So we can stop that. I'm going to show you the angiogram now. We can go to the angio pictures. So this is again EDP. Was normal, being hydrated, being diabetic, creatinine. We did some, we gave dye yesterday, good hydration this morning. The right looks beautiful, and here we are. So you can see that tram track calcium right at the, this is our good old way of defining calcium. I know imaging is a gold standard, but we can still go with the angiography. We can see that heavy calcium at the left main to distal where it's bifurcating. And this is where we are. You don't appreciate the distal left main so well here, but you definitely start seeing the distal left main, proximal LAD, and the bifurcation at the with the DAG also involved. And why I did this cranial view is again to define the same lesion, but more important to understand is circumflex involved or no. Angiographically, it looks like it's not involved, but we can have a discussion what to do. So then, of course, while waiting for, this is another view that I wanted to tell you is as operators, decision not only based on imaging, you can make some other decision. Here, look at the way the wire actually is traversing from distal left main to LAD. In this situation, if we, after imaging, decide we are going to do some kind of atherectomy, we got to be cautious in selecting the burr size. So this was the imaging. We can just show that right now, Kiski.
Yep. Can we share the IVA screen?
Very complex case.
Can you show the IVAs on the screen?
Can we, okay.
Okay, I review the probe. This is a 4 millimeter per second Boston Scientific high definition IVAs. A lot of calcium, yeah, approximately 360 calcium, left main bifurcation. So I review the first, come back to the distal left main. So distal left main has like a 270 degree of the calcium, and the tightest area of the left main, like 3.8, is significant. And this is the left main's bifurcation. And the most severe calcium is proximal LAD. We see the 360 calcium. This is a proximal LAD. And this is the level of the diag. The opposite part has also calcified plaque, so risk of the D1 occlusion. And the distal LAD is kind of like small shrink vessel, like 3 vessel. And the left main side is follow, like huge size discrepancy. So this is the IVAS work.
So if you go back, why with the question is always is what kind of a burr can we select? So distal left main, if you go there, it is just about 1.6 diameter. So, you know, can we do 1.7 by burr from distal left main to LAD? Yes, probably okay. But more, if you go to Austral LAD where you have 360 degree calcium, right there, yes, yeah, right there, 360 degree calcium, it is just about 1.5 the burr. You see the diameter. So this is how based on imaging you can select the burr size. Question is 1.5 burr or 1.75 burr. Dr. Sharma, if you can talk on that, and then we'll say what we have here, and we are ready to rota. We'll be going up with the rota burr as you do the discussion.
Yeah, Dr. Kenny, Dr. Sanjeev Sharma. This is such a roomy left main, and there is 270 to 360 degree arc of calcium, and it can accommodate the IVL balloon. We can go with a 3.5 IVL or 4 for the left main. It's not that tight, so either you pass one or two passes of 175 burr, and then you can take a 3.5 IVL.
Sorry, what's the burr size you told us? 175?
175 burr. Because LAD is 3.5, you can use a 1.75 burr, followed by IVL for the distal left main. That is very roomy, and it's a 270 degree arc of calcium in the distal left main. So distal LM, because the 1.75 burr is not going to touch your distal left main calcium.
Yeah.
So
that's a great.
Yeah.
That's a great point. Yeah.
1.75 burr. If you can show the angiogram once again so that audience can see it once again. And I know the IVAS gurus will decide based on the IVAS. I will decide based on the angiogram. This is a large vessel. Even if the circular calcium of the LAD, it's a reasonable to go with the 1.75 burr. Because 1.5 you can go, but you definitely will require such a heavily calcium additional IVF. So let's say, Ramesh, what will be your vessel?
Yeah,
what will be your burr size?
I agree that 1.75 appears to be good, but also probably I could also say that the orbital atherectomy also is another option. So either one, because I think if you decide to go with the 6-inch radial and you don't want to upsize the burst, use orbital atherectomy at 120,000 RPM in the left main, but only 80,000
You have a
in the
3.5 IVL ready?
Okay. So basically, it's 1.75 little
Why not orbital atherectomy?
or orbital.
Because it is the good size vessel, long lesion. So I think orbital atherectomy is the best.
So for us, actually, we choose Rotor just because in the United States, it is still cheaper to use Rotor than orbital atherectomy.
Yeah. Even here, even orbital atherectomy, I think 50,000 more than the rotational atherectomy, even in India.
Right.
So in America, the orbital is $800 more than the rotor. Okay, tell us what you are doing now.
Okay, so we actually went with 1.5 bar only because of that the wiring was not that easy. Okay, here, remember I took this just to say that getting into the LED was not easy with that
Right.
angle. We will have wire bias, and I hope this 1.5 bar will do something. Otherwise, of course, we will go with the IVL. So going back, is orbital atherectomy a good choice? With that kind of calcium, yes, I think it is a good choice to go with orbital atherectomy, but somehow, always people prefer with one or the other. So we went with rotational atherectomy, yes.
I know I was actually surprised because that angio showed the calcium and the wire. I was expecting actually a calcified nodule on imaging. I was surprised not to see one in this patient.
Yeah, no nodule actually.
We can get the IVUS ready after this, yes.
Since the IVL has become almost 8% of the lesions at present in USA, of the 1 million cases are being done 8% with
Okay,
IVL.
come.
The Rota used to be 3.5, orbital used to be 2.2. Both have become half. Little more decline in the orbital since the eclipse start. I mean, we used to do about 10 to 12 orbital before. Now we do maybe 1 or 2 because fellow wants to learn. Because that's the technique they need to know once they go to private practice or wherever. There may be only orbital atherectomy, not the rotational therapy. So definitely orbital has significantly went down in United States since the eclipse start. Okay, so 1.5 bar is done.
Yeah, I'm going to quickly IVUS, but let us decide what do everybody think about the diag and of course and the circumflex. Then we will tell you what are we planning.
No, but we still have not identified. Did you ever identify, was there a circ lesion or no?
I mean,
Possible circ.
angiographically, no, but now everybody will tell me do IVUS. So this is the cranial view because you don't see it well in any other. In the caudal view, you could not see it. This is the only view you could see the circumflex.
Yeah, there is a lesion at the ostial circumflex, intermediate, 50 to 70%. I think we need to tackle that, or you can do a IVUS pull back from circumflex to left main.
All right. Tell us what is your next step now.
No, I'm just going to do the IVUS on the rotor wire. Or you want to put a run through anyway, because we have to do, even if it is we need something, we have to get the run through wire. We will do the IVL ready, because if we need the IVL, it has to be at least 4 may be too big. Maybe based on the IVUS, I think we go with the 3.5 for the distal left main, right?
Yeah, 3.5 I think is a reasonable choice.
So this morning we had a nice talk by
Yeah,
Dr.
3.5 will
Nagendra.
work for both LAD proximal as well as for distal abdomen. 3.5 should be okay.
Right. So this morning we had a talk about imaging, role of imaging in making a difference in bifurcation, stenting by Dr. Nagendra Chauhan. In your opinion, Dr. Sharma, in this patient, even if there is osteocircumflex involvement, it is a simple bifurcation, right? So would you do imaging, or would you just say that, okay, I'm convinced it's okay to go with the provisional stent strategy?
Yeah, so I mean, again, I personally believe, I know a lot of people may not agree with my statement. I think the imaging in complex case should be reserved for the end to get your best results. Rest to decide based on the angiogram. So here, I'm still not convinced that osteal circ is there, but if you take a little better picture, no problem, you just across. But you know, if it's angulated circ, even 30, 50%, you know that if once you put a stent, it will be very tough to wire and put a second stent. Then you go with the two stent strategy. So means if there is a, you feel it's a, will be difficulty in wiring, go with the two-stent strategy, even in the intermediate side branch. Okay. So doing
Okay.
another
We are doing another IVAS run. Then what is the, so everybody thinks you have to wire the circ and decide. We are going back. Okay, now Kiski, tell us
Okay,
what we
click the
did.
image. Okay,
Oh,
start.
oh, in this one, yes.
Start to
See,
work.
we are
Submit
like I
LED.
always keep telling, we are trained with our eyes. Okay,
Yeah.
I call it
Box
EYE
LED,
IVAS. Our eyes
360.
have been trained. So in this
So left
case, that's
main.
why I went a couple of
Yeah,
views
I
to
stop it.
show that the osteocirc is not involved. So in that situation, I think we, if you ask me, without imaging, we'll do just a provisional stenting. But more important is the diag. I know it's not moderate size, but it is reaching there. It's like a 2.5 vessel. It is significant disease based on every criteria. There is, this vessel could go down, start giving slow flow and chest pain after we do the procedure. So should something be done? Okay, show us the
Yeah,
IVAS.
so yeah, I showed it. This is a proximal LED. So even with the IVAS resolution, no clear like calcium fracture. But when we go back and forth, I see some hematoma. This is just after the 360 part of the calcium, like a huge plaque modification. And just proximal to the 360 calcium, also some like this haziness. This is also the dissection of the plaque. So between the fibrous and the calcified plaque. So I think the proximal LED is a good plaque modification. And come back to the left main. Also, IVAS resolution hard to see the calcium fracture, but lumen is definitely bigger. It was like 3.5, now it's like almost 5.
Okay.
So this left main also, I think it's a good plaque modification.
So one fiber did its job. The main reason I think what we proved here is that there was significant wire bias, which we detected earlier on when we were wiring the left main to LED, where I showed that when you have this kind of wire bias, downsize your burr. And when you is telling a hematoma and dissection, that is why we got to be cautious. You know, in certain cases, we definitely has to be cautious, and we have been. So I think it has done, and you already see the diagonal, you know, telling us bye bye. So I guess we got to work on that. Now let us decide what is the next step here.
No, I mean diagonal is a good size vessel, 2.5, and there is an osteal lesion, very short.
Okay.
This is the case. Even if you decide the crossover technique, maybe if the little cutting balloon of the diagonal, but leaving the wire definitely will be the approach. I mean, you can't ignore it, because once you put a stent across, wiring will be a little more difficult. It's better to do the wire now. And if you need to modify ostium after you've done the balloon of the LED, whether IVL or high pressure or cutting balloon, whatever the strategy is, take care of the LED, take care of the diagonal ostium, and then put a stent across while waiting, deciding for the osteal circumflex. So length of the stent will depend on if you want to take care of the circ also or not.
Reason I was asking is, now what will happen is once I wire, I do not like to take the wire out of the diagonal, because this is a kind of the vessel that will close on us. Then will be a 3-wire technique here, that if you have to then IVAS the circumflex. Okay, so we have a 225 cutter ready. Give it to us. Let us do that. Kiski,
what do you want to do for the LED now?
No, that's the question I'm going to ask Kiski, and then I'll tell you what I think we should do. Based on the imaging, right, Kiski?
Yep.
Do you think there's a role for IVL, or we have done a good calcium modification?
So in the proximal LED, there is already dissection and the hematoma. I think it's a good, even we go more aggressive, it's a risk of the more injury, like kind of perforation or something. So I think it's good to go stenting.
Once there is
the balloon.
Yeah, we will do the balloon. No, we are not going to do. No, we'll do a balloon. The question was IVL or no. I think we have done enough, especially once you see that kind of a dissection. Go back, show what is the dissection and hematoma. Hematoma definitely bothers us, you know.
Yeah, so this is a hematoma like at 1 to 2 o'clock, and the little proximal part, like 6 o'clock, there is a dissection. So yeah.
The
Okay,
Question,
good.
would cutting balloon be better for a hematoma before you place a stent?
Go.
I think the audience was making that comment, right?
You can do a cutting balloon or pipe NC balloon and then the stent directly.
I would just do NC balloon.
Yeah.
Ostial, the cutting balloon of the ostial. Yeah.
I know, Ramesh, there are a few people who believe if there's hematoma, do cutting balloon so that hematoma can be resolved.
Right.
Our question is not that, microperforation. So I guess here we can just do high pressure balloon. What do you have? 3038. So, you know, distal LAD was just 30, and there's a bridge starting right, I think not after the septal, about 15 millimeters after the septal. So we need to avoid that. Okay. Go up again. So I did a couple of runs of this here. Okay, good. Go up here. We went up to 18 atmosphere with a cutting balloon. Good. Okay, down.
What size cutting balloon? Is it 2.5?
225. So that is another question always comes, native vessel. Okay, so you go smaller size. If it's instant restenosis, you can go same size of the stent, but ideally we like quarter size bigger. Now take a picture, Anju. Okay, give us a balloon because LAD flow is being compromised. 30, right? We have a
30.
30.
Yeah, but teaching point of view,
Mm.
after you've done the rotor, while you wire the diagonal, take care of the LED first. Optimize your LED result, then go to the diagonal. Because if we start LED shutting down, your whole process will become very acute, and you have to rush it. The whole purpose of these good techniques are that you are able to do step by step in a very controlled, calm manner.
I think here the initially
Yeah.
LAD had much better flow. Maybe the hematoma is expanding now
Yeah.
as we are waiting.
There
So
could be a plaque shift after diagonal ostial
plaque
derivation.
shift also is a possibility from the diagonal.
Yeah, that was a very interesting point Dr. Sharma mentioned, that you take main vessel and side branch, yes, but here if you see the diag flow was becoming a 2.5, not 3 yet, so that's why we make sure diag is okay. Now once I do the balloon of the LAD, we may lose the diag again. The question now back is, what are we going to do with the circ?
I think Circ, I would go provisional stent strategy.
Yeah.
I
Keep it provisional.
keep your, whether but the question is whether you want to keep a wire. This is a 7
Down.
guide system.
Hey.
So you can keep a wire.
Keep a wire, do a latment to ready and then rewire, do a kissing and decide.
But now you see that the dissection and hematoma is telling us that that was a good modification.
Yep.
Look at the expansion of the balloon.
Yep. Excellent.
Let's take a picture here. If everybody okay, we are not going to image the circ. Okay. So far diag is okay, but diag we may lose again. You want a caudal? I want to go back to the left main, I think. You never saw the ostium of the circ in any views. Okay, we will take some more.
Circum is ostial disease in aleocaudal view. It is 70 to 80%.
Yeah, it looks diffuse.
We need to fix that. I think we need to have a stent for circumflex ostium also.
Hello, can you hear me?
Yes, we can hear.
Okay, great. I am Dr. Praveen Chandra. I have just joined online because I had to, miss my flight because of certain reasons. But now I am in the session and I can see you doing the case, a fantastic case. So to me, just now I had a look. It looks like the circ ostium is okay, not too bad.
Yeah. I think I agree with Dr. Praveen Chandra. If you ask me what I would do, I want to make sure the diag is okay. And if
Yes.
diag looks okay, we put a stent across. Now, what does other people or the moderator, Dr. Samin Sharma, what do you think? Let's take a picture.
I think it's still the plus
Questionable.
minus. I mean, to me, the only region is that, Praveen, my region
Yeah.
would be there is a moderate lesion of the ostial circ and it's angulated. So
Yeah.
wiring will be difficult. And then, of course, your subsequent device, if your crossover technique will be more difficult. Just for that region, even with the moderate circumflex. Now, only question you can say, you know what?
Give the wire.
Patient is 81 years old, right?
Fielder.
71. Yeah, 71 is young. Yeah, young. 71 is young. Yeah, 71 is very young.
Okay,
The
if
diagram
everybody
is good.
wants.
That's okay. You know, since you are the operator, you tell us. You teach us what you want to do.
Remember,
So
I
you're
am.
saying,
Yeah. Okay, go. Let everybody say what they want to do
yeah.
then.
So Dr. Samin is saying that you should put a wire at least
No,
before
no,
you.
I'm saying the other way. I would say the diagonal looks good. Put the wire in the circ, and then maybe
Yes.
do a cutting balloon of the ostial circ and do a mini crack. That is what I'm saying. I
I
mean,
mean,
let's say I'm doing the case. That's what I will do.
I would wire the circ and go to stent.
yes, I mean, I
Because
will
the
put a
angle
wire
is
in the circ and put
acute,
the
the
stent across
angle
the
is
left main
acute, and there is
because
distal lateral
circ
flap,
doesn't look, or
which
maybe
will
image
bend
the
towards the
circ
circumflex
ostium.
ostium, so better to
Image the
use
circ
the
ostium.
stent as a stent spray.
Okay. So you guys are telling that diag looking good, remove the diag wire or leave the diag wire, we put a third wire in the circumflex.
No. Put the diagonal wire in the circ.
Okay.
But we said do whatever you're comfortable with, Dr.
My comfort is very good. I'll put a stent and come out. That's it.
Yes.
In fact, I would have done the same thing as she's saying
It's like
because to me, circ is okay, and put a stent
it
which
was
with
a
the open,
it was a
the
complex
open
case.
stent.
We need to keep it simple.
Yeah.
Fielder.
Oh, fielder. Okay. It was a complex case, we believe, but we are trying to make it remain how we can handle the complex case in a simple way. But let us make it complex now. Okay. Okay. So let us. I'll get divers. I don't know if this has the curve. So
Yeah, you're there.
curve might have been gone now with the.
Yeah, it is going small branch.
After stenting is impossible.
Look for a
I
new
may have to
fielder.
change the curve. Yeah. There's a small branch. As soon as the circ takes off, it just keeps going to that branch.
Yeah. You might have to change the tip.
Oh, get me a new fielder. This is gone. Go. Fielder. It's gone.
Which stent are you planning to put? Do you have any, particular selection of stents or any stent? Because when there are side branches, like there are diagonal and the circ, will you have a particular choice of a stent?
Not really. I mean, we usually use, either a Zion Synergy. So it's not of any particular choice. Both are okay. Nothing like you use a thin strut stent or ultra thin strut stent, which is we currently carry O0. None of that. We use all of them. And during our live cases, I think you have seen we have done cases with all of them.
Yeah. No, I totally agree. But we have a certain selection in such side branches. We use open cell designs like Onyx or Biomatrix, or sometimes, because I see that particularly closed cell design stents have higher chances of, branch occlusion.
And actually, the megatron of the synergy, which we'll try to use in the large vessel of the left main ostial lesions, even give more difficulty to get to the side branch. You
Yes.
cannot occlude the side branch, but it's difficult to get to the side branches.
So in
compared
this
to other
case,
open
if
cell
you have a
type of stent.
Onyx on the, on the shelf, I will use a Onyx or a Biomatrix or some open cell design. Yeah.
Megatron is a hybrid. There's a closer on both sides, open
Okay,
cell
some
in
dye
between.
there.
I think it's
Get me a run through, I guess. I have a run through here.
I think you need a run through wire probably there.
Yeah.
And there is a little ventricularization, so I think you have to come all the way up to the ostium of the left main.
No, we are deep. We are deeply engaged into the distal left main.
Yeah. So
That's the
maybe you have
reason to get into the
That's
circle.
why
No, no.
To facilitate the wire going into the circle. But Dr. Chandra, we don't have that luxury of having 5 stents anymore on the shelves.
Really?
In
Why?
the United States.
What's
It's
the
only
reason?
you have to give 90% market share to 2 stents. I don't know, Dr. Sharma, at your place, it's same actually. So the rest of the market share will be another 1 or 2 stents if at all. So either that would be traditionally be between distributed by Abbott, Zions, or Onyx, or Synergy. So Cyro shares maybe like 1 to 2% market share.
I mean, here the situation is so different. At any point in time, we have at least 10 or 12
you
varieties of
just came
states.
out guiding slightly outside and
The
then
guide
go,
may be too much.
because
Guide.
guide is go quite
Yeah.
inside in the vessel. So you just came slightly outside guide and then an acute turn it goes in LCS.
Guide is quite
It's
far away.
it is nothing to do with the guide. I think the wire has to be such a
if you
hyper
have
acute thing.
almost a
Yeah,
L,
the bend has to be
it'll go
changed,
away.
that's all. I
Or the
agree with
whisper
Dr.
wire.
Rani.
To make a
Yeah.
soft tip.
Or the whisper.
What I think it's telling us, just stent across and finish the case.
I agree.
Absolutely.
Yeah, this is
Absolutely.
like,
Go ahead and
You,
do
Yeah.
it.
you probably once you put the stent, maybe the angulation might be better with the. I don't know. I mean, I'm just saying we can make it, as Dr. Kinney said, make it more complex. But
Yeah.
for youngsters in the room, that be aware of this, and as long as the TIMI3 flow is there, you can put a stent, especially if the pressures are going down. Pressure is stable here, Yeah.
somehow, no, it is in there going to the small branch.
Oh.
Now another
It is
small
going-
branch. It's going to every branch except that, except the main circle.
I think you should stent the LED and that's it. Left main to LED.
Okay.
No, it is better, better.
Yeah, it is, but
Yeah, gone.
That is gone.
Gone.
Which wire they run through?
yeah. Okay, get us the IVUS.
Yeah.
Now, after wiring, now what is the plan?
No, we are going to
IVUS.
IVUS.
I was to the Sir costume.
IVUS will tell you lumen is 2 millimeters square.
Okay, good.
No,
Take a vote. Take a vote.
It will be big.
Yeah.
I think it is 4.
4.
At least above 3. 3.5 to 4. Yeah.
I'm saying 2. Let's see.
Three.
Yeah,
Okay,
check the image.
Kiski.
Okay, start feedback. This is proximal circ. It's coming. And eccentric plug. This is osteo circ. Yeah, looks tight. I'll stop it. Yeah, quickly check the osteo circ area. So,
No, ostial circ or distal left main?
so this is a distal left main,
Okay.
and this is left main bifurcation. So yeah, this is osteo circ. And 1 second, we need to some edit. So I think around 2, as Dr. Sharma mentioned. So this is the osteo circ area. Yeah. 2.2 square millimeter. Very focal lesion, but there is a tight stenosis in the osteo circ.
Okay,
I
so
will
then
just
get
line
us
your
a
cut and then put a stent,
get us a cutting balloon, which will be 3.25.
Millimeter cutting.
because I have to decide on the stent size for the circ. Let's go back. So the stent size based on the eyes will be, we did a picture there. Oh, there. 3 to 5. 3 to 5? What's the
Yeah,
stent size IVUS is telling us?
EL size is 3.6. So yeah, one size down.
No, give me
but-
lumen. Don't give me EL.
Yeah, lumen is actually there's some diffuse plaque. The lumen is like 2.7 or something. The proximal circ.
So,
I think 3 or 12 will be good.
Three will be
no,
also
not 12.
fine.
You need a longer. Once you do
longer,
that, yeah, put on the, because otherwise we'll struggle again re-entering that. Get us a 18, 3018, and then we have the 38 stent, 38 for the left main.
318 is the right choice.
380.
Yes.
Oh, now we have a trouble. Okay, good. Because so that's one thing. When you have issues with wiring, it could be intertwined at the distal left main, which has not. Okay, down. Pull back here again. So now we can use this to do the distal left main also. Okay, now, okay, get us a stent, right? Go up here. Fully expanded. Yes, down. There was no calcium anyway in the ostial circ. Give us the stents. 3018 and 3038. And a 408 balloon for the left main.
Wolverine was 3 millimeter. Wolverine for cutting for the circumflex ostium.
3 to 5.
3 to 5. 3 to 5.
And
All right, you got few minutes now. It's a 3 plus, let's say 1 extra minute, 4 minutes now.
we can show the Philippe left main mini crush. So I'm going, this is the circumflex, right?
Circumflex.
I will show the bifurcate app and the steps of mini crush in the bifurcate and what exactly will be done in the case, as we have shown it in multiple trials. I mean, multiple or live relays.
So same, go to the side branch first. So that's where we are. Now park the stent a little bit distal. Now we will get, now since it is a 38 stent, oh, we did dilate. Okay, good. Now we go to the LED. Now since both are run through, it will be a little bit difficult. Usually if it's a fielder run through, the color of the wires are different, so it's very easy to identify. Now we have to make sure we are going on the right wire. Yes, so this LED wire. Now since we are doing mini crush, we have to be sure. I don't think we have to come up to the ostium. You have the IVUS, this time I had the guide out.
I think mini crush is also a very good technique for this kind of bifurcation.
Get a filter wire. Oh, we have, right?
I
Let me the
also
same.
many times use the mini crush technique now rather than going for the DK crush. So it's quite good.
Thank you, Dr. Chandra, for supporting Mount Sinai technique.
No,
Okay.
I learned it from you people only. So
Yeah, come sometime.
that's why from Dr. Sharma and you all.
It saves time, and in experience hand, I think it's almost equal, both mini crush and DK crush.
Yeah.
Oh, wait. This is not the issue. So I'm getting, this is the side branch. Okay.
This side.
Okay. Go. I'm going to pull back the
Yeah.
a little bit into the left main. Okay, now. Okay, good. Okay, go up with the circ. Okay. Down. Go up again. Okay, good. Down. Now we have to make sure the distal circ is okay. Some dye. Okay, good. I'm going to get this. What did you say? I'm not coming to the ostium of the left main. Kiski.
Yeah. Left main has diffuse plaque. You come more proximally more healthier.
Okay.
Vessel size is 4 low, left main.
Stent is Zines.
Huh? Zymes.
Yeah.
The Zymes.
Okay, some die. Very good. Yeah, okay, go up. We have not seen the distal edge of the where the stent is going to land.
Yep. Because if need to be, you can always put a
Yeah, additional stent. Okay, down. Go up again. Get us a 408 balloon. Okay, down. Now when I recross, I will use the fielder wire. Now you have to be very cautious here that you are not get the fielder wire. Yeah. Oh, where is it? Yeah. Okay. Take a picture and then we recross. LED actually looks okay, distal edge on the caudal. Diag is still flowing.
Yep. 4.
Yeah, we can show the EKG. EKG looks good.
We can come back to see the result. Final result. We can have one talk. In 10 minutes, we'll.
Yeah, so I
Go to
think
that.
what we do, that's an excellent result of the mini crush. Of course, you go through the regular technique of the pot and kissing and then imaging. So maybe after one talk, we can come back. No,
Speed
and,
IVs. Yeah.
otherwise, case has been done very well,
Yeah.
step-by-step technique.
Congratulations to the
Thank
Mount
you.
Sinai team,
Thank
Dr.
you.
Penny,
Thank you.
Dr. Sharma. We had a fantastic result.
Thank you, guys.
Bye.
We'll come back after one talk. So one talk can be Dr. Chandra's first because he's online already. So we go to the Dr. Chandra, Praveen Chandra, he's online.
Are you seeing the wiring now or they disconnected us?
Oh, just got disconnected.
Disconnect.
Okay.
See, we can go online to Dr. Chandra Medanta, Delhi.
Yeah. So can you hear me and see my slides?
Should have
Yeah,
done
we
pot
can
first.
hear you very well and we can also see your slides.
Okay.
So
So
we can't see your slides. It's
you can't see
Show
my
the
slides?
final result.
Yeah, that's it.
yeah, here it's
I'm
not, yeah.
screen
it's,
sharing.
big screen. It's Mount Sinai.
It's
Okay.
unnecessary for the circ wiring.
Elizabeth, can you switch?
Can you see the slide now?
Not yet.
Not yet.
No, now it's okay.
Yeah, it's okay.
Not on big screen, but here we can see.
Sanjeev?
Yeah, yes, we can see. Yes, we can see. Yeah.
Okay, so should I start my presentation?
Yeah, you can, please.
Okay.
Why
Okay.
it's not going,
So
right?
thank you very much,
Okay,
and
good.
I'm so sorry that I could not make it at the
Go up.
last minute because of
Don't
some
go too high there.
issue
good.
here with one of the patients. But the patient is okay now. Everything is settled. So I returned actually from the airport. So now I'm doing my
Wait.
presentation from the
Okay,
hospital
good.
itself, and this is a quick presentation on Impella assisted high risk PCI.
Okay, go up.
So now the question is, why
20.
should we do?
No need.
it's not
Down.
moving, huh?
16.
Yeah.
So why?
Please.
What is the agenda for this
left main
talk?
was 4.
So
I know,
first of
but
course is why we should use
we are
LCS
outside
for
little bit.
high risk PCI.
Okay,
Then
now
I
you
will
can
tell
go
you
here if
briefly
you want
about
20.
how we do it, and
That's
then
in
what
the
are the
LED also.
outcomes.
Okay,
And some
That's why I
cases
was
I will
thinking.
share,
good.
and
Down.
also
14.
share with you what are the complications, how we prevent
We
them,
have a
and of course
3012
the
high
take
pressure
home
balloon.
messages on this.
We'll take that.
So with this, why we use
Do we kiss with just
LCS
this?
in which kind
No,
of
4
patients
is
in
too
complex
much
high risk
for
PCI?
LED.
The patient
Then
profile
get us a
is one of the
30 or
very
15
important things
high
which
pressure balloon.
determines
Get a
it.
3 or
And one
15.
of them is severe
3
kidney
or
dysfunction,
hold on. What
severe
did you give?
multivessel
3 or regular
disease,
balloon
left main disease, and patients with high syntax score or
or high
surgical
pressure?
ineligibility.
We can take high pressure.
Okay,
Last
give high
remaining
pressure.
vessels, hemodynamically unstable patients
3 or 12
also.
high pressure
12.
also.
12.
So how does Impella help us? Impella helps by
You want a
active
2 or 12
LV
balloon
unloading
for
and
search?
forward flow
3 or
during
12?
the entire process of intervention. It allows complete meticulous revascularization, and it helps avoid intra-procedural instability while we are doing the procedure. So repeated episodes of hypotension or ischemia does not happen that much when the patient is on Impella support system. So what have we done up till now? We have done more than 100 cases, and these are high-risk cases and the mean ejection fraction was 28% for us,
No,
and
it'll go.
30% of our patients were having left main with severe triple vessel disease, and also sometimes
this balloon will
last
go?
remaining
Yeah.
vessels. The procedural
was just
success
that.
has been
Like
94%,
four also
and
ran,
in-lab
took
mortality
some
was 0%. So that is very important, that actually you can, bring your
Good.
patient out of the cath lab without any serious issues. And of
Got-
course,
No, give
complications
me
do
the other
happen,
LED
which I will
balloon.
share with
Okay.
you. So how does it happen? So basically, the heart team has to be in sync.
No, sure,
fair.
12.
So we
30 will not
generally
go now.
discuss with
No,
our surgical
or you want a 3,
colleagues
5, 12.
also that we are doing a high risk
For what?
case, and generally
LED.
we do it. That is why when everybody is
3
around,
3 or 12.
in the,
3 or 15,
the
15.
morning hours, or when the whole team is available, the heart failure, the anesthesia, the CCU, everything should be available, and of course should be on support. The the cath lab which we generally use is a normal cath lab which has all the hemodynamic monitoring, ECMO support, everything should be available, perfusion support, and of course the ICU readiness should also be available in these patients. So
Okay,
the
now go up on the
pre-procedural
LED.
heart team hurdle
on
should
LED,
always happen.
20.
That
Good,
what is the
down.
plan, what is the the backup plan,
Do you want to
if
do here
something
also?
happens,
Yeah,
what
little
should
bit
we
go.
do in this
Not
situation?
distal because there's a bridge
So
there. Okay.
with this
16.
I
Okay,
will
good.
just
Down.
move the slide. Yeah, okay. So this is the the basically the
Okay, now
workflow that
go
once
circ
we have selection
18,
of the patient
20,
who is less than
because it is a 3 to 5
35%
vessel and
mostly,
we have a 3O.
complex anatomy, and of course I
Okay, good.
discussed
Down.
already with you
Now,
what are the features. Then
LED
optimization
again,
is
18,
done
and
with
then we do the case at
hemodynamics
8 or 10.
first, and then we do
18.
of
Good.
course
Down.
we check the PA pressures, we
Go
do
both.
vascular ultrasound
8.
mapping, and then the access is done
8
with
now.
the ultrasound guided
Okay, down.
access in these cases.
Now, hold
So
on. They will say the
most
dots
of
are
the
not
times
at
we do
that
ultrasound
point and
guided
this and
access.
that and all
And
this.
this is done with the ultrasound guided
Okay, good.
micropuncture.
Both the dots are together.
Then a
You understand what I'm
pre-closure is
talking?
done in all
Proximal
these
dot.
patients
8.
with one
We
proglide
don't
or two
pay that much,
proglides,
but the live case,
and
somebody will
an
comment.
alternate
Down.
axillary access is sometimes sought if femoral is unsuitable in these cases. The device strategy is like, we
Okay, I
first
was
put
ready.
these
Yeah.
patients, if they are on IBP, we
You want
remove
to
the
take a
IBP,
picture so we know
change
we're
it
good?
for an Impella,
Ready?
or
take-
directly go with the
Right,
Impella CP Smart Assist device, which is the one which is available. Earlier, the Impella 2.5 was available, which is not available anymore. And then the patients are given heparinized purge, the ACTs are checked, and of course, backup pacing is, if required, is done, otherwise not. Now, the standard checklists are that we anticoagulate these patients well, the purge protocols are run, and we do real-time ACT tracking and hemodynamic monitoring all the time. And of course, as I discussed, that escalation pathways are always
I think we can
have
do
to be
both
kept in
sides.
mind. If
So that
I'm going
if
circ.
there's no
this
question
happens, if
asked
this doesn't
afterwards.
work, patient goes in arrest, what we will do.
Flash.
Then protamine reversal should be available, because when we are removing these sheets, big sheets, and hemostasis plan should also be in position, like having a angioseal, or sometimes even manta can be used in these patients. And of course, the nurse should also be trained, and the team should be well accustomed to deal with
Okay,
these big
Yeah,
sheet
Circumflex.
check the image.
follow-up care, and bleeding surveillance
starts
is
to work.
very, very important, because
mean-
you do a good procedure and the patient
Yeah,
bleeds,
it
it's not a good
looks good.
idea. Then clinical,
On the
what is
plot.
the
Beautiful.
evidence of
Yeah.
consensus on when to use it? It's a clinical expert consensus which
Get
was
us a
done
good
with us in
MSA.
India.
No.
And
Let it
these
Yeah,
are
come.
the
austere
people
circuit
who are
5.6,
involved.
so it's
And
Don't
here
yeah,
do
good one.
inside. That's what I
see
mentioned
that
last time. When you
5.6.
this is
advancing it,
the
don't do that.
basis on which the clinical aspect, on the
5.8.
technical aspect.
It's looking good, right?
Yeah, looking good.
Distal edge is good?
Yeah,
on the plug, that looks
less
good.
than 3 or more than 5.
Okay.
So this is
going to
hemodynamic,
remove this
patient
wire then.
characteristics, coronary anatomy, and procedural characteristics.
I need
So
too
this
many
can be
wires.
a very easy way to assess the risk in these patients. And of course, the difference from the many Western algorithms are there. So here we have taken a syntax score to 32.
It's too many
And the
things.
hemoglobin less than 8 has
Diagonal,
been excluded.
circumflex.
And EF less
Yeah.
than 25% is 2 points.
We
And
mentally, I
age
was
more
not
than
prepared for
75 is 1
circumflex.
point. So
Otherwise,
that
you
is
could
the
have moved
change
fast, you know.
from the
No,
various
but
other
that's okay. I
guidelines.
think
There's
it
the
was a good
Indian
discussion.
algorithm, which we can definitely easily
Everyone
use,
wanted circumflex.
for
Yeah.
selecting whether
Only
this
me and
patient is a
Chandra
good
didn't want
case for,
circumflex.
this procedure or not. So in our series, what we have done is that
I hope
so
bag
the
is good.
total number of cases I
Bag
already
would be
shared
okay.
with you. High risk PCI was 86, cardiogenic shock
Don't
in
take
32
renal picture.
patients, single surviving vessel
EKG is
44,
good.
and age
Okay,
more than
distal edge of the
75 was
LAD.
27 patients,
start-
complex multi-vessel
start
PCI
back.
58, unprotected left main 31.
Oh, wait,
and
wait, let
many,
me go a
of
little
course,
distal.
were
Hold on.
calcified
You think we
vessels.
got it?
And
Okay,
here
now
you
go.
can
No,
see
no, no,
ACS
I
was
stopped.
28%,
Okay, go.
low
Okay,
EF
start
Okay,
back.
good.
6%, and
Coming.
also who had valvular problems was about 30%.
Yeah.
Yeah, nice.
On the
So this is the
slight
year on
glitch.
year,
Yeah,
how
yeah.
did we,
But no
kind of,
dissection.
went up, because as you gain
Looks good area.
experience, the team becomes
area.
more well versed.
Nice.
Now,
more
nice.
and more cases.
Yeah,
very
looks good.
important, very
you know,
important at the distal left
included
main,
in
you have to
this,
show the circ stent is crushed.
program.
Yeah.
And this
Because
is the
they will,
procedural
that's
success,
another
as I
thing they will
already
ask,
told you,
and they will
94%.
criticize us for that.
So what is the evidence
Yes,
behind
see?
using
So no,
MCS?
no,
And
no
these are the
septum. So
various
it may
trials.
it
The
clashed.
Protect
It
2 and
clashed.
Protect
Well
3 are
modified.
the main important trials, which showed improved 90-day outcomes in high-risk PCI. In
Well,
terms of
nicely
both,
crushed, right?
death,
Yes.
stroke,
Good.
MI, and repeat revascularization, and also in patients with ineligible CABG
Some
patients,
nitro.
it has shown
Okay.
a very
100 of nitro going in.
significant improvement in hospital mortality after matching, and this
Good.
is the
Ready?
data which we
Yeah,
have, and also helping to get a complete revascularization with less contrast nephropathy. That is
really
also very important point, that AKI
Diagonal
is
is
also
there.
Proximal
minimized
edge is
because we
okay?
have less
Yeah, on the
hypertensive
plaque, but-
No,
episodes
proximal
during the entire
of the
procedure.
left main is
So,
okay?
Yeah, yeah.
It also
Good, good.
reduces,
Okay, this is the only thing that we are a
MACE at
little
90
bit
days,
worried.
and
No,
there is
no,
a
I think it's
44% reduction in the Protect 2 study, as you see, between Impella versus IBP. So IBP
Beautiful.
Diagonal is
and
there.
Impella now completely, and that is why IBP has,
Good
we
job.
are
Yeah,
told
That's
that
why no
Mackay
EKG
has
changes.
stopped production
Yes.
of IBP balloons, and only it is available from other companies which are still making it, but Mackay has stopped producing these balloons. So the lower mortality and the length
Disconnect
of
the
stay is
flash.
also is very, very important factor.
No, you want to start
which
closing?
determines
Yeah, we
that
can
Yeah, yeah,
close.
these
because,
very sick
they all have
patients
to go.
can be
It's not
now
like a
treated
regular
with
day.
greater efficacy
Where's
and
my-
lesser risk.
oh, hold on.
And significant benefit has been demonstrated.
Can
in
I do
high-risk
like this?
PCI with
Is it
Impella
working?
support in these big
Yeah,
studies?
this is what.
So these are some cases which I am showing you. This is a post-bypass patient and has
Start making that
multiple problems, CKD, liver disease, everything.
Right.
And he had undergone angiogram few years back. At that stage, we thought that probably it is not a good idea to do anything. And the lima is also not functioning well. The vein graft was only one graft was functioning, and that was also quite of diseased. So we said, okay, let us not do anything. Let's keep him on medical therapy. But then he again came with a very bad angina and heart failure. And this was the last remaining native vessel, as you can see here, which was heavily calcified and was showing a lot of, tortuosity. So at this stage, we decided to do this with the initially balloon predilatation followed by shock waves, and you can see it was very difficult to actually cross this unless until we did
Give me
some
new gloves.
serious aggressive dilatation even using OP and NC balloons. But during all that, the patient was having hypotensive episodes which were maintained with Impella, and we were able to do a good job with the help of multiple dilatation, shock waves, etc. And then followed by that, we even treated the vein graft, and the vein graft also did quite well. And we were able to complete the whole procedure without any difficulty, and the patient was then discharged in 2 days' time. The patient did very well. He underwent a check angiogram because he had some vague chest pains, etc., and also showed in 2 months later that everything was doing well. He did very well after that. Then similarly, there is a patient who underwent a bypass surgery. The grafts failed within 3 or 4 months of this surgery, EF was low. He was brought
Oh,
in the
Djokovic
emergency,
lost.
put on a balloon pump for initial stabilization, and then we did an angiogram. We discussed with the surgeons, and they said it's not a great idea to go for another surgery so soon, and also the disease was very extensive, as you can see here, from left main into the circumflex. RC is completely occluded, so there was no
We are
way.
coming
They
back,
were,
right?
they put up their hands up
That's what they
that
said.
this
Okay.
is not a great idea.
Good.
So we
You
we
showed it, huh?
decided, okay, if we have to do it,
I
we have
never.
to do it
You
in
showed it.
Impella. So many times we removed the pump on the table and then put the patients on Impella through the same access. And most of the times also we are doing single access. So through the same access, we do the intervention. And here you can see that we put the guide catheter, which is a 7
We
French
can
guide catheter.
tell Samin Sharma.
And with this, we are able to then put the wires in and started dilating. And as you can see here, multiple dilatations. And during dilatations, this was happening. The pulsatility was going down, but the mean pressure was maintained. And we were able to recanalize the left main, the proximal LAD, circumflex very well, and got a very good result. And the patient did very well after that. So this was almost impossible earlier, but now we can do these cases. Then sometimes even if you have to do a ultra low contrast PCI in a patient who has very low GFR and has multivessel disease. So here you can see that we were able to do that with root ablation and even with a second birth, pre-dilatations.
Good, we changed the
and
case.
with bigger
That
balloons
case would have been
followed
nothing.
by stent implantation in the main vessel from the left main to
The other patient is so
and got a
upset.
good result, and the impella was explanted immediately. So overall, our outcomes have been very good. The bleeding rates have been very low, 4%.
They're coming?
Acute kidney injury was also quite low, and the length of stay
Did
is
they
generally in the ICU is about
respond to
1
you?
day, and then the total about 3 days in the hospital. So what are the complications we watch for? And here are the complications, the vascular access complications, detection of hematoma, bleed, all should be kept under check. And the second is in those patients where the catheter remains inside for more than 24 hours, hemolysis is something which has to be very carefully seen, and we have to do some, troubleshooting like purging, positioning, and optimization so that no hematuria happens or no hemolysis happens. And then, of course, arrhythmias and everything else has to be optimized.
Yes, coming back in 1 minute.
Finally, just as a final take-home message, Impella gives a superior support compared to an intra-aortic balloon pump in very high-risk patients where you need LV unloading to reduce wall stress. It facilitates longer, safer PCI. It enables complete revascularization in complex CAD, even if it is a last remaining vessel, low ejection fraction, left main disease. And the evidence is there now from all these studies like PROTECT2, CVAD, USPELA, higher procedural success and trend towards improved outcomes.
So we are going to show this, okay?
Optimal patient selection, early insertion, and meticulous large bore access will maximize the benefit and minimize complications. Thank you very much.
We show the angio, okay?
Go live now.
Are we live?
Yeah. Yes.
Okay, can we just go to full angio before you show IVUS?
Yeah. Okay.
No, take the IVUS out. Yeah. Oh, okay.
Good. Yeah.
Okay, so we are showing you. So remember we always predicted that. I just wanted to show you. It took only few seconds to cross. After we stented the circ, this was a fielder wire now. Then of course we did our steps, which is we did pot before kissing. So the question also comes in the study, which should you do, pot first before wiring, after wiring? I think for most people we will say do the pot first, which is left main proximal optimization followed by rewiring. Then we did the kiss. We took a 3O up to 1820 atmosphere of the ostial circ, another 3O of the LAD. Just at that, and then we did the kiss at about 10-12 atmosphere. This is the final picture, and we did the IVUS of both the branches. Now go to the IVUS.
So this is the first pullback from the circ. Distal edge looks good, well opposed, no dissection. And most important is MSA of the osteocirc. This is 5.8. It's well expanded.
Okay, good.
Now come to the final pullback from the LAD. So yeah, distal edge looks smooth, transition, well expanded. The 360 part area is like 6.9. Now come to more proximal. This is left main bifurcation. The proximal edge is on the plaque, but no malapposition, no dissection. And the distal left main MSA is now 8.3. And the left main bifurcation is no septum. It means it's well modified mini crush technique. And this is the level of the left main bifurcation.
Yeah. So listen, this question always comes that, okay, you did mini crush. Did you actually cover the ostium or no? Go back to the IVUS, stay on the IVUS. So we are just showing again that struts are few millimeters are in the left vein, not even few, maybe one strut or so. You can see that at the where the circle is bifurcating, the struts are there. Go back. Acceptable is 8, and we have just reached there. That was 4.0. Just at the distal left main, we went up to 18 atmosphere, and the left main, that's the way it looks. Let me show you the distal. Remember, we never took an angio of the LAD to make sure that distal part is covered. In the IVUS, we show that it is now nicely covered, but we want to look at the angio. So this is the, go back to the final angio. IVUS is good. And this is the final cranial angio. The diag is still patent with the TIMI 2.7, 2.9 flow, but it is flowing. But more important is no EKG changes. You can
It
show
is
the
actually
final
a
EKG.
TIMI 3 flow. It's a TIMI 3 flow. It's not 2.7.
Okay, go back to the second one. Show the hemo. So these are the things that we go with. The final TIMI flow. If you really go to a cranial view, you probably will see the diagosteum does have some disease, but as long as patient does not have chest pain, no EKG changes, and we are going to do another 12 lead EKG before we take the patient out, and we have a good TIMI flow, then we don't need to go back to the side branch as we have seen here. And this is the final. Did we do another caudal picture? Yes, that was the final caudal picture.
Yes. Yeah, there is a question by Dr. Rajababu here.
No, there's a comment.
Comment, okay.
Yes. TIMI is the best and always right.
All right. With that, we end. It's beautiful. Fantastic.
Thank you.
Very good case.
Thank you.